Ladies and gentlemen, we'll start this afternoon session. This meeting is a dissemination meeting for the Day Surgery Data Project, DSDP, which has been an important project run by colleagues in the IS and other colleagues over the last few years. And I would like to call on our President, Carlo Castoro, who will give a talk about the role of the IaaS in European initiatives.
Thank you very much, Jan. Dear colleagues, good afternoon. I would like to talk to you about the European projects and the role of Scientific Association looking at the IaaS experience in this field. Excuse me. As you know, the role of Scientific Association in the aims could be really many. I put here only some of these objectives. So we are a network. We can do research and innovation. We can actively collaborate with educational programs. We can also set guidelines and a recommendation. We can act on policy and policy makers. We always try to drive changes also, but we also take care of information to patients and provide evidence for decision maker. One important task is to monitor results, for example, but also we can be active in professional accreditation. Taking in mind this role of the International Association for Ambulatory Surgery, these possible roles, let me give a short view on the possible role of the IS in the European project. Well, we can certainly be a vehicle for dissemination and visibility of results through different methods. The website, electronic and other paper publication, but also in meetings such as this one today that has the main aim to disseminate the results of an European project. We are a hub for networking in the field of day surgery for us among professionals, managers, and policymakers. This is an added value at European level for the participation of the association into international projects. And we can be provider of expertise in the field of ambulatory surgery for, again, an added value to international initiatives. So we are certainly convinced that things are rapidly changing, and to change things we need data and indicators, because we must prove to adapt quickly to the needs changing, and we must be flexible and innovative. And being a multidisciplinary network of experts is certainly a good position to start. That's why we invested a lot during these last years in international initiatives, as you may know. And I want now to show you how we worked inside the Day Surgery Data Project. That is one of the two projects co-funded by the European Commission under the Program of Community Action in the Field of Health, of Public Health, in the period 2008-2013. The starting date of the project was 1st September 2009. Here are all the main partners, all the partners of the project. As you can see, the main partner was the Italian Agency for Regional Healthcare, that is based in Rome, that takes care of the regional health organization. Associated partners were from Belgium, the National Institute of Health and Disability Insurance, from Denmark, the Association of Danish Regions, for France, two partners, the Haute Autorité de Santé et la Caisse Nationale d'Assurance Maladie. For Hungary, the Budapest Medical College here. Again, from Italy, the National Agency for Regional Health Services, and the University Hospital of Padua, from Portugal, the Centro Hospitalar do Porto, for Romania, the Clinical Emergency County Hospital, and for UK, the King's College Hospital in London. And the IS, as you can see here, is a collaborating partner. That means IS is not entitled to receive a grant from the European Commission, but can work as an advisory board, a collaborating partner. Okay. The general objective of the DSDP project, Day Surgery Data Project, was to identify a set of day surgery indicators and to develop the information systems on day surgery in Europe, a very ambitious one. There were some specific objectives. The first was to review existing day surgery indicators at international level. The second, to assess day surgery data and indicators in all participating countries. The third, to identify and test day surgery indicators. Then to standardize data and indicators and define a set of day surgery indicators. To develop guidelines for day surgery indicators presentation, and to promote the use of information and knowledge on day surgery services. Here is a spreadsheet of the total work plan. If you are familiar with European projects, you know well that all your project is divided into work packages. Some are only administrative and general work packages in this case 1, 2, and 3, and technical work packages that we have 6, as you see, starting in 2009 and finishing in August 2012 last year. Looking at specific objectives, Work Package 4 addressed the topic reviewing existing day surgery indicators at the international level, was led by Paolo Lemos in Hospital do Porto. And the method used was a review of relevant literature on day surgery indicators, the creation of a list and a critical analysis of indicators available from international organizations, primarily EU health indicators projects, and benchmarks and gaps in current data and indicator identification. At the end of Work Package 4, a deliverable that's almost a book, more than a little booklet, was produced, and as I will show you afterward, all the documentation is available on the website. Work Package 5 assessed day surgery data indicators in all participating countries. It was an analysis of availability, reliability, validity, comparability, and so on, and interpretation and utilization of day surgery data and indicators available in each member state. Again, a deliverable that you can find on the website. I will show you. Work Package 6, identify and test day surgery indicators. A research protocol concerning the assessment of validity and reliability, including a list of indicators identified for testing and empirical analysis, and then a research protocol concerning indicators comparability and validity, a very difficult task to reach this one, and a report identifying the most common gaps in current day surgery data. Work Package 7, standardize data indicators and define a set of day surgery indicators useful at international level. The aim was to create 2 separate lists of day surgery indicators, one minimum and one ideal, and the fact sheet of day surgery indicators. Again, a deliverable on the website. To develop guidelines for day surgery indicators presentation was Work Package 8, and a set of guidelines ready for the dissemination phase. The last work package was to promote the use of information and knowledge on day surgery servers at European level, and to make available the lessons learned by the project and all the recommendations to all relevant stakeholders and publish a policy brief on this topic. As you can see, each work package was led by a different partner. This slide is only to show you how complex is the organization of such a project according to the rules of the European Commission. You see, we started here with a literature review. We reviewed more than 3,000 papers. We came out with 95 day surgery indicators at first, and in the second phase, we reduced these numbers to 22 day surgery indicators to be studied more in depth. Here are some more details. Again, an enormous amount of work done to review relevant papers, both peer review, great literature, EU projects data, and health database all over Europe. 95 indicators selected. One important task was reached was the classification of indicators into 9 different categories. Indicators of input, of patient characteristics, of access, process, output, effectiveness, safety, cost efficiency, centeredness, and satisfaction. And we came out, we learned that the great majority of indicators found in the peer review and great literature, 95% of indicators identified, are not integrated in any kind of health information systems, including the latest EU project and the International Health Database. That's just to focus the need of such a work. Here is the enormous amount of papers produced. The final meeting took place in August last year in Padua, in Italy, and Mr. Guy Darjanc, that could have possibly been here today, but unfortunately couldn't come for a last-minute change, was very, very supportive, and the results were just very good in the opinion of the European Commissioners. So good that recommendation to implement the surgery information system into EU indicators framework were done in the joint action for ECHIM, that is another European project. Let me show you some results and recommendation. We remember the aim of the project, that is to identify sets of day surgery indicators and to strengthen day surgery information systems in Europe. 95 indicators into 9 categories, as I showed you before. What we learned from this part of the study after reviewing day surgery indicators available in member states. First, that there is a wide variability in terms of availability and structure of the single indicators across member states. No standard definition of day surgery among member states exists. This is a major problem. And again, no standard definitions of data and indicators in the single member countries. We had also to face the problem that we are working with different coding systems, as you know very well, from ICD 9CM to Scandinavian and CSP, French, or British or OPCS, and transcoding not always very easy and feasible. Robustness of indicators was seen as problematic. Several indicators were not integrated into any kind of information systems, and no standardized processes of data collection and presentation. This can lead to the conclusion that current information systems do not allow assessment of day surgery unit performance in all member states, nor comparison. This is most important for us in the international perspective of day surgery systems among countries. So we worked also in trying to identify a set of day surgery indicators through the Delphi methods. In the absence of data, we try to find an agreement between experts with the Delphi methods. with different consecutive rounds of questions and answers. Here you can see some examples of the question and the agreement reached. For example, the first day surgery, ambulatory surgery, is a procedure without night stay that requires full operating theater facilities. We reached an agreement of 93%, and you can see all the others till the last one, that is assertion number 5, that is the set of basic indicators for the national, regional level should be different from that selected for the day surgery unit, because the information needs at these two levels are substantially different. We reached an agreement of only 75% in this apparently obvious statement. I don't know if you can read. Yeah, probably. Yes, there are some examples of the indicators examined. After the first set of 95 indicators, we came out with 22 day surgery indicators. Indicators of input, such as full-time equivalent surgeons, including the pediatric surgeons dedicated to day surgery unit and percentage, and so on. Access, average waiting time for basket procedures in general and day surgery unit. Process, percent of patients who have received the pre-anesthesia assessment. Output, percent of elective surgery performed as day case, or percentage of day case of day surgery discharge or no surgery discharge per procedure. Outcome, mortality rate within 30 days. Safety, unplanned overnight admission, percentage of day surgery admission requiring hospital transfer. Percentage of day surgery admission who experience a wrong patient. Percent of surgical wound infection. Indicators of satisfaction and responsiveness, such as percent of patients who considered they have received good preoperative information, or number and percent of patients satisfied with selected dimensions. And cost and productivity, such as expenditure on day surgery care, a percent of total health expenditure, average rate of rotation in the operating rooms, surgical theater use, mean operating time, percentage of cancellation of surgical procedure without notification by the patient, failed to arrive or did not attend, a cancellation of the book procedure after arrival the day of surgery, percent of diagnostic and operative endoscopies carried out in a day surgery unit. And we came out after this selection with a reduced number of essential indicators. So what's the result of this international project? Well, the Day Surgery Data Project does not have the illusion of providing a definite answer regarding ideal and essential set of the surgery indicators. There is no single right answer to such a question. But organization, technology, and procedure continue to evolve, are in continual evolution, so we need to adapt to this evolution, changing also our indicators as needed. National and local contexts are very, very different. Just to show you how the implementation of measures supported by policy making could advance improvement. This is an example of the performance of US hospital on 4 reported quality measures. In these 2 graphs you see on the left side, the percentage of antibiotic administered within 1 hour before surgical incision, after issue of recommendation. You see that since 2004 to 2009, there is an incredible increase in the percentage of adherence with guidelines. And on the right-hand side, percentage of antibiotic discontinued within 24 hours after surgery. Again, an example of how implementation of measures can change our practice and influence practice. Obviously, day surgery represents a deep transformation under many aspects, from structure to processes and patterns, and the integration of design structures, processes, and patterns is necessary to achieve a coherence and to lead to a day surgery information system. So what are the recommendations? Member states should adopt the agreed definition of day surgery, ambulatory surgery, office-based, and short stay. This is obviously the first step. We must compare comparable things. The second recommendation is, whenever possible, use a common list of basket procedures, such as the OECD list, possibly modifying the list if it is not so good for the evaluation of day surgery as it could. Classify day surgery indicators on the basis of different categories. We propose 9 categories. Reconsider their current sets of day surgery indicators. And a few words on the role of scientific association. What could be the role of the International Association for Ambulatory Surgery towards member states? Well, we should try to force them to endorse a small set of validated structural process and outcome indicators after reaching a broad consensus among all the stakeholders, in this case, managers, providers, and citizens. Put pressure on government and parliaments to pass legislation mandating public reporting on hospitals, also communicating these possibility with patients. Create a longer list of indicators for all different purposes we have, and ensure policymakers are aware of the importance of measurements and allocate sufficient resources to this component. Obviously, this is very ambitious recommendations. This is just a quick overview. I invite you to visit the dedicated website that is www.dsdp.eu, where you can easily find all the original documents and all the data you may want to read. Thank you very much for your attention.
Thank you very much, Carlo. We'll have a discussion at the end. So our next speaker is Roberto Gnisotto.